Okay, good morning, everyone. We're going to go ahead and get started. Good morning to everyone online. Welcome to our Department of Pediatrics Grand Rounds. And I wanted to, since we have just one more Grand Rounds in our season before we take a short break in August, thank a special thank you to Savannah Ryder, who has done an amazing job coordinating and passionate promotion. And thank you to Raiden and Terry for all of the support that they give us for setting up here and making sure that everyone has a great experience. So with no further ado, we have really an incredible lineup for you today on a really important topic of adolescent substance abuse, and really three impressive rock star physicians who are working in our community to improve care. Dr. Abigail Schlesinger is a child and adolescent psychiatrist and associate professor of psychiatry and pediatrics at the University of Pittsburgh School of Medicine, with an interest in increasing access to quality behavioral health and developmental services for children and families. She is the chief of child and adolescent psychiatry and integrated care at UPMC Western Psychiatric Hospital and Children's Hospital Pittsburgh, and the medical director of Children's TIPS, which is training and implementation for pediatric psychiatry, an important provider-to-provider consultation service. Dr. Schlesinger was instrumental in the development of children's community pediatrics, in getting the behavioral health service off the ground, and that is the service that embeds therapists and psychiatrists in pediatric primary care. And this service has won local, state, and national awards for efficiently improving access to care. Next, we have Dr. Michael Lynch, who is an associate professor of emergency medicine, toxicology, and addiction medicine at the University of Pittsburgh, where he works clinically in several of our UPMC hospitals, including Children's Hospital Pittsburgh. He is currently the senior medical director for quality and substance use disorder services at UPMC Health Plan. Dr. Lynch previously served as the first medical director of the Pennsylvania Department of Drug and Alcohol Programs and was the medical director of our beloved Pittsburgh Poison Center, go Mr. Yuck, for 10 years. He is the founder and director of the UPMC Medical Toxicology Telemedicine Bridge Clinic. And finally, we have Dr. Maggie Shang, who is an assistant professor of medicine and pediatrics in the Division of General Internal Medicine and General Academic Pediatrics. She practices both a combined adult and primary care at Turtle Creek, as well as integrated addiction and primary care and inpatient addiction medicine consultation. Dr. Shang's work focuses on care for individuals with substance use disorders across the lifespan, with a particular interest in expanding addiction services for adolescents and young adults. And she does this through educational initiatives. Excitingly, she serves as the program director for our first adolescent and young adult addiction medicine fellowship, which is funded through HRSA, and just started with their first fellow this year, which is super exciting. She is committed to advancing evidence-based patient-centered approaches to substance use care with a focus on stigma reduction, care models, low barrier treatment models, and evolving unregulated drug supply. And the evolving unregulated drug supply, I should say. As a co-founder of the Harm Reduction Research Collaborative, Dr. Shang contributes to the interdisciplinary efforts exploring the intersection of clinical medicine and public health, with an emphasis on improving systems of care for structurally marginalized populations. Please help me welcome Dr. Schlesinger, Lynch, and Shang.
Thank you. You may recognize I'm not Abby Schlesinger. Mike Lynch, nice to see you all. So yes, we're going to be talking about adolescent substance use and hope to provide some practical, but also, of course, evidence-based, resources for you all to know what's going on, what's out there, and how we can start to address it across different specialties. There we go. We have no disclosures. And here are the learning objectives. So we'll talk a bit about current trends, certainly what's out there, and how to apply SBIRT framework, evidence-based interventions, and then provide some resources that are actively available for you all, because of course none of us expect anyone to be a specialist in addiction medicine after this 45-minute presentation. We want to make sure that sort of the foundation, the identification, but then what do I do next, right? If we ever ask anybody to screen for something, it's unfair not to say, and this is what you do with that information, and that's a goal of ours here today. So I'm not going to go through each of these things, but I just want to set the sort of foundation that the words we use matter. Stigma is such a driver of barriers to access and to even engagement, right, for people to talk about it. And a lot of that stigma is rooted in words that sometimes we don't even recognize as words that can be stigmatizing. Things like dirty versus clean, abuse, substitution or detoxification, or addicted babies, right, as opposed to a child or an infant going through withdrawal. So those kinds of things, basic tenets of person-centered language, we will try to follow, and of course we all hope to model for our trainees. So I'm sure I'm not telling most people in here anything they don't know when we point out that the most commonly used substances among adolescents are alcohol, nicotine, and cannabis, right? So over time, we have seen reductions in overall substance use across adolescents, and that has been good. In particular, cigarette smoking, we know that vaping is its own thing. We've seen a spike, and fortunately, most recently, a bit of a decline that we'll talk a bit more about later. But overall, the use of different substances has gone down, which is an encouraging trend. At the same time, while death related to substance use is still relatively uncommon among adolescents, you can see that it has risen significantly. And unfortunately, like many things, it does not rise always in an equitable way. But over time, in the last half a decade, and a lot of that has to do with what's out there and what all people, including our adolescents, have available to them, whether they know or don't know what it is that they're using. And it's also important to recognize that the earlier an adolescent or a child uses any substance, particularly in a risky way, the risk or likelihood that they develop a subsequent substance use disorder is higher, right? So it's not surprising, but some data to kind of show that the earlier somebody starts using, the more likely it is that they are to develop a substance use disorder. And we want to really impact that as early as possible to try to kind of divert, if we can, or provide the resources to support the underlying motivations that lead to that. Really want to touch on some of what's out there, right? And again, I think we all have some awareness of this from popular media, THC in particular, and I put CBD, not so much because CBD in and of itself is overly dangerous, but things that are sold as CBD aren't always just CBD, right? We know that THC concentrations are really important. We also know that there's lots of loopholes and ways that people try to get around sort of hemp allowances, right? Because it's derived from hemp, but if it's delta-8 THC and there's a bunch of it, we've definitely admitted people to the PICU because they ate a bunch of gummies that were delta-8 THC. And they were bought legally by parents who often didn't even recognize that these were potentially dangerous things that kids can get into. And of course, people know intentionally that they can get the psychoactive effects. Lately, kratom has been increasingly important. I know in our practice, 7-hydroxymetragenine, which is sort of both a breakdown product, but also a very small constituent of the kratom plant, is much more potent as an opioid. So people can go into a store and buy essentially an opioid, gives them opioid effects. Fortunately, rarely an overdose that leads to death, but it does lead to tolerance and dependence, and over time, withdrawal when people stop using this thing that they didn't even know they were using, a substance that can cause that. And so that's really important. There is actually work done in the state and at the federal level to schedule 7-hydroxymetragenine and other related compounds that we're working on that I think will actually be a useful use of scheduling. Not always is scheduling the right tool. Here, I think it is because it's so widely available. I'm sure we've all seen in our communities, you don't have to look too far, right, before you see signs in stores. Tianeptine, this came out as the gas station heroin was the term that was applied to that. It's essentially a tricyclic antidepressant and can have those kinds of effects, but also has opioid effects, can lead to overdose with toxicity, seizures, and then withdrawal as well. We don't tend to see as much of this, at least clinically and anecdotally around here. The 7-hydroxy, I would say, is clearly the most emerging large threat that we're dealing with, leading to kids getting put on things like buprenorphine to treat. So it's a big deal. A diverse supply. So, while it's uncommon, we know that kids and adolescents, whether intentionally or unintentionally, get into the drug supply, and the drug supply is increasingly diverse, right? There's many things added to it. So fentanyl is bad enough, but now we're dealing with things like xylazine and metamethadone that cause their own acute effects. And for those using intentionally and over time, the withdrawal really dangerous. We're not seeing a lot of metamethadone withdrawal here at Children's, but we are seeing a ton of it over at Mercy and Presby, multiple patients per day being admitted to the ICU because of withdrawal from this stuff. Again, that's just added to the fentanyl supply. And that doesn't even get into stimulants and other things that are being added and will be. So just knowing that the supply is different, there's a lot in it, and it complicates the clinical picture for acute toxicity and withdrawal. And a lot of people don't know what it is that they're getting, especially adolescents. And then pressed pills. So a lot of times people try to avoid sort of dope or fentanyl or heroin because they know it's bad and they know it can kill them. So they actually spend more to buy pills because they're like, well, at least I know what this is. Unfortunately, you don't know what this is. So these two pictures, or left and right, are oxycodone, 30 milligram, versus what was fentanyl pressed to look like it. They're essentially indistinguishable, right, to me, let alone to anyone, including a kid buying a baggie of it, right? And you can see the explosion of pills pressed, and it can be things that look like Xanax, things that look like oxycodone, and they have fentanyl. And of course, people don't realize it, and they lead to overdose that is unintended and death. So we've seen a ton of this, really important, again, for education and awareness. So that's just a brief, sort of lay of the land, and I'm going to turn over to Dr. Schlesinger.
Thank you. Thanks, Mike. As you can see, this is a potpourri of, sorry, I changed my slide. Let me get it back to work. Okay, so this is a potpourri of a wide variety of things that we thought would be useful for pediatric primary care and other pediatricians to know about substance use. Sorry, what is going on there? Okay. I didn't want to start without reminding people that if you have a patient that you're going to see again and you are concerned about what to do for behavioral health or substance use, you can call TIPS and we will help you. The other thing is that you're not going to learn everything you need to know about expert substance use in this presentation. Obviously, it's only 45 minutes. But if you want more training, I know Maggie does training as well, as you can call TIPS and we'll come to your practice and help you learn more about how to intervene. So as we are a training facility for physicians, for APPs, for psychologists, we have to talk about that there is a evidence-based diagnosis criteria for substance use disorders that includes 11 things that fit into cravings, control, meaning taking more than intended, consequences in any part of life, and dependence, which is tolerance and withdrawal. And the people that look at substance use disorders have broken this down into mild, moderate, and severe. But I want to be clear, I don't really expect pediatricians to have to figure out, is this mild, moderate, or severe by the DSM diagnosis, right? We do have a diagnosis, it's used for research, but when you're seeing patients, we were just talking about, oftentimes you can look at a patient, you can tell, have they accrued all the things in their life that are problematic due to substance? And you can tell pretty quickly how much of a problem it is, right? And obviously, as pediatric providers, we don't want people to get to severe, right? We want to get there early. We want to prevent the lifetime outcome. And when it comes down to deciding whether someone needs treatment, it really comes down to how many problems have accrued, how much consequences are they having, and what a lot of substance use providers and people in the field say is continued use despite negative consequences, right? And consequences could be in any realm of your life. Physical, meaning withdrawal and tolerance, although for most drugs, for most kids, their bodies are so resilient, they don't develop that. But other consequences, social consequences, and using more despite knowing that it's affecting their physical health or other concerns. So what is SBIRT? And I got into this 20 years ago, not because I'm a substance use expert, because substance use is so ingrained with behavioral health, right? Most kids with a substance use concern will also have a behavioral health concern. So most teenagers you see that have substance will also have behavioral health. And it's just the way it is. And for a long time, we didn't talk about behavioral health. Then we didn't talk about substance use. Finally, we're starting to talk about both. And the recommendation is really, SBIRT stands for universal screening, meaning we should really be screening everyone. We don't have time to do everything we're told to do. What we do in outpatient now is screen everyone in their well child visits, starting at about age 12, which is the recommendation of AAP and has been hugely effective at helping us see sort of who's using what and then figure out where to go next. And then the BI is brief intervention and then referral to treatment. We often joke that a lot of this in pediatrics is really SBI, right? Screening and helping to know what to do, whom. We actually rarely, quite frankly, refer to substance use treatment, but if you need to, we can help you in tips. Think about how to do that. So there are a ton of tools. This is only several, but the ones that are highlighted there, the CRAFT and the S2BI, are the tools that are available in our system. They are available in EPIC. They were built by the pediatricians in EPIC with support from psychiatry. And when we go live, God help us, at the end of October, these will all, CRAFT and S2BI will be available for all providers. And we wanted to really, for this presentation, focus on what could be actionable. So we wanted you to know what these screens are. The S2BI is really these questions. In the past year, how many times have you used tobacco, alcohol, and marijuana? Now recognize no screen is perfect, right? We know that. And a lot of kids don't see vaping is using tobacco, so sometimes you need to follow up. We really see screens as an entree to start a conversation, right? So if a kid fills out any of these, you should have a conversation. Just like as a kid walks in and they're wheezing, you're going to want to know more about what happened with their wheezing. Or if they walk in with having an asthma attack, you're going to spend a little bit more time making sure you get them stable before you move on. I would say the same thing for substance. If any of these come up positive, you should spend a little more time on the substance, because the odds that that's going to cause long-term harm or short-term harm is much higher than kids that don't fill this out at all. The interesting thing about the S2BI and why we liked it is that they actually stop at those first 3 questions if none of them are positive, because the odds of having the ones below are less. But if any come back positive, they move on to the next question. And the kids can answer never, once or twice, monthly or weekly or more. As you move down, so from never to weekly or more, they're more likely to have a substance use disorder, sort of as I talked about above, what a substance use disorder is. If any kid is using any of these weekly or more, the chance that they have a severe substance disorder is pretty high. I'm going to repeat that again, because I can't tell you the number of times I've gotten calls where someone says, well, they're only drinking weekly. That's actually a really high risk. And remembering that is really important, because they may not know that they're at high risk of a problem unless they hear it from us. And then the CRAFT is added to the S2BI. This is actually in line with national recommendations, and a lot of people have heard of the CRAFT and not the S2BI. I'm not going to read it to you, but I think there are some really important things related to risks that could be accrued with substance use here, related to driving in a car with someone, using it to relax or alone, forgetting things you did while you used. Obviously, that's a huge risk, right? Being told by friends that you should cut back and not cutting back is a huge risk, right? So one of the things we wanted to talk about, obviously, you can't work with kids or be around kids without realizing there's some unique things about adolescent brains, right? I like to think about the adolescent brain as like a fast-moving car, that the brakes aren't quite where they need to be yet. So it's got everything it needs, but they don't quite know how to use those brakes effectively, right? And the car is really driven by social environment. So if a kid's social environment is telling them to cut back and they're not, I would be really worried about that kid. And then have they gotten in trouble while using? So as the first part of the S2BI, as you move up on the CRAFT, you're more likely to have a substance use disorder. And it's pretty specific and sensitive, even at 2 and above on the CRAFT. So, and to remember, screens are not diagnostic. They're an entree to a conversation. If someone tells you, allows you in and gives you the information that they're using some of these substances, it's an opportunity to find out what they're using, how they're using it, where they're using it, and the consequences. They've allowed you into information that they probably don't share with adults pretty easily. And that's a really special place to be. Also, remember, as I said, most of these kids are going to have some sort of comorbid behavioral health. Not all of them, but most. So understanding what other behavioral health concerns they have, family history and treatment history will really help you sort of figure out how to help them move forward. So once you screen, then where do you go next? As I said, the first thing you do is sort of diagnose where they are, right? What do they need? What do we need to go forward? Brief intervention, we put these up to allow you to see that there are different frameworks for brief intervention. We're not going to go through every one of these today, but there are some things that exist in all of these frameworks that I want you to leave with today. Every single framework starts with, if you used a screen and you think you're concerned about someone, you give them the feedback about the screen, right? It shows that you've looked at the screen, and it also shows that there is science associated with these screens. So saying something like, you filled this out earlier, and it suggests that you're at high risk for substance use disorder, right? So just saying it as a fact. What do you think about that? Giving them a chance to engage in a discussion about what you saw and what it's connected to. And then listening. So we were talking earlier about how the waving the finger doesn't work, right? So realize what I said before wasn't waving the finger. It was just saying you did this form and it suggests this, right? Which you do for every other medical condition. What do you think? And then stop and listen. Because what we want to listen for is why they're using, what's driving it, what consequences, why do they like it? In fact, that's like one of my favorite questions to start with because they don't expect it from a doctor, right? Why do you like this substance? What does it do for you? How does it help you? Because then that starts the conversation instead of in this sort of, because they expect you to say stop, right? They don't expect you to say, tell me how it helps. And then they may move on in their own about how they've thought about stopping. So all of these frameworks can be really useful, but if you just remember to step back, give them the feedback about the screen and listen for those actionable items around how it helps and what they've thought about, even asking them, have they thought about quitting? You can skip the frameworks and that'll get you a far way. The other thing that I want to remind people is, like, as doctors, we love to give advice, right? We love to give advice. We love to learn about more advice. Advice doesn't work if a kid's not ready to hear it. So that's where that listening and MI skills can come a long way. And I'm going to put another plug in that if any of your departments want more training about MI, we have a ton of experts that can help with that and help you develop that in wide-ranging things from substance use to even vaccine hesitancy. That can help. So once you listen, then it's about an action plan. And any positive change is good, right? A lot of times kids have had little action plans in their head, but they haven't really thought about them enough yet, right? So you can really help think through it and give them the breaks, right? Think ahead of time about what the breaks are if they're in a situation where there's substance or if they're having trouble setting limits. And finally, referral to treatment. Remember, again, most kids that have a substance use disorder will also have a behavioral health disorder. So the problem often is figuring out where they fit best. That's another thing we'll help with tips. A lot of these kids start in general IOPs, and that does the job. Others need to move on to substance use services. And we'll talk more about pharmacologic, but that's not referral out to treatment. You could actually do it on your own, especially for nicotine replacement. And then there's a ton of evidence-based services that work for substance. And this is another thing that tips will help with you. But they all should come down to, so there was a little red thing that I must have deleted. So the bottom thing there is risk reduction. All of these services should really be working on harm reduction, risk reduction, meeting the kid and the family where they're at and helping them move towards, if not abstinence, then a healthier lifestyle. So a very basic thing that we could talk for ages, but we're not going to, is when to break confidentiality. This is not unlike suicide. If someone is at risk to themselves or others and is a teen and as a pediatric provider that's not a substance use provider, it's really incumbent on you to think strongly about breaking confidentiality. If they're impaired driving, families can help them, right? You're only going to see them once a week, once a month, once a year. Parents are there every day. If they're being coerced into using and they need help. And then the younger the children are, which is on the far left side there, the more likely you are going to want to break confidentiality, both because as they get older, they get more rights around confidentiality, but also the younger they are, the more likely that substance use disorder is to cause difficulties and end up in lifelong concerns. So an 11-year-old that reports monthly alcohol, I would break confidentiality as a primary care doctor because that is a really high risk situation, as opposed to an 18-year-old, it might be different, right? 21-year-old, definitely different. And ultimately, what we can't forget in this world is how important family is. Family engaged in treatment improves outcomes, improves engagement, improves everything about long-term implications. And when you talk to adult providers for substance use, they also often say people with substance often don't have families involved in their treatment because they've burnt out already, right? We have an opportunity as adolescent providers to really get the family engaged early and to change the long-term outcomes. And at that point, I'm going to refer to Maggie, who's really the real action here.
Thank you. So we're going to talk more about some practical guidance of what you can do perhaps in your practice, and involves things like prescriptions. Before we dive into that, I think it is helpful to understand a little bit about the world of vaping. I know Dr. Lynch alluded to some of this earlier. Electronic nicotine device systems or e-cigarettes, they don't produce smoke by burning tobacco. They basically heat up a solution, which is called an e-liquid, that then releases this vapor that people can inhale. These have been on the market for a while and actually were developed initially to help adults with quitting cigarettes. And so there's been many generations as you can see here, starting with things that looked more like cigarettes to now more advanced devices that have the ability to be refilled, recharged, and also have potential ways in which you can modify the device and how it delivers the nicotine. I will say the big difference between generation 3 and 4 is the use of nicotine salts. And these are like less irritating when inhaled, when produces a vapor, and can actually deliver much higher concentrations of nicotine. And while there's been FDA regulation, there's not necessarily a cap on the nicotine concentration for these vapes. As you can see, this is just a general vape. Primarily, what you can see here is the tank, which is a coil which heats up the liquid. The liquid can consist of things including flavoring, other sort of additives, and then typically some psychoactive component, could be nicotine, could be THC, or something else. Something else that's been popular, as you probably have heard of, are Zins. This I pulled from Reddit. This is like a Zin tower that people are making. And has been trending on TikTok. But these are basically pouches that also contain the nicotine salt. So this is different from things like snuff or chew, which contain tobacco leaves. You put it in between your lip and gum and essentially absorbs to your mucosal membrane. And these can deliver anywhere between like 1.5 to 16 milligrams of nicotine with each pouch. So it's pretty variable in terms of what people are getting, but very probably much higher amounts of nicotine than what we typically prescribe as like nicotine gum or lozenges, which is anywhere between 2 or 4 milligrams. So speaking of nicotine replacement therapy, I think this is something that we can do in the inpatient setting as well as the outpatient setting. And typically I think about it in this like basal bolus method. So the patch is really what delivers a even amount of nicotine throughout the day. It keeps sort of the nicotine withdrawal at bay. And then when there's breakthrough symptoms like cravings or withdrawal, they can utilize things like the nicotine gum or lozenge. These can be available over the counter for those 18 and older, but they are available via prescription for those under 18. And the one thing I will say with the gum is it's sort of a misnomer. You should, it's not something that you just chew like gum. Essentially what you do is you chew it for a little bit. Once you get like a peppery, tingly sensation, you park it in your cheek and you let it stay there until that sensation goes away, and then you chew it again, but don't continuously chew it because it does not work that way. The other thing I think that people ask me is like, well, what dose of patch or gum should we provide for people? And so you can see here, there's different doses of nicotine patches, 7, 14, and 21 milligrams. Inevitably, you should be starting people either on 14 and 21. It correlates with how many cigarettes that someone is smoking. And again, with the adolescent population, frequently they are vaping. And I will say it's very hard to determine how much nicotine someone is vaping. And so there are estimates where it's like, oh, well, if they have half a pod a day or something like that, they would require something like 14, or something more than that, you would require 21. And so I would say it's like your best estimate. You're probably not wrong to start them on a 21 milligram patch and sort of de-escalate from there. This is a helpful guide sometimes too from an educational perspective, and also a question I get asked a lot, which is like, how many cigarettes does that equal? And so the way I think about it is like a cigarette delivers 1 to 2 milligrams of nicotine. A pack is 20 cigarettes, so it's anywhere between 20 to 40 milligrams of nicotine. And again, the amount that's delivered depends a lot about someone's like inhalation practices, metabolism, et cetera. You can see these are examples of different types of vapes. And essentially the way I think about it is like, what's the concentration of the vape, similar to how we think about alcohol by volume, nicotine by volume, and then how much volume is in that e-liquid. And then you have to think about how long does it take for them to go through that pod in a week, in a month, whatever. So for example, Juul, I think that's something we hear a lot about. It's 59 milligrams per milliliter, which is their nicotine by volume concentration. Again, it depends on what kind of Juul pod, but most of them are 0.7 ml. So if you do the math, it's around 41.3 milligrams of nicotine, which if you divide that by anywhere between 20 to 40 milligrams of nicotine is like 37-ish cigarettes. So again, very, 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 very approximate kind of estimation, but this is one way that you can think about it. And again, can be helpful in terms of determining the nicotine replacement therapy. There are also other tools that, especially we use in the adult setting, that can be helpful. You've probably heard of varenicline, also known as Chantix. There was one recent study that was published looking specifically in the young adult population of 16 to 25-year-olds that demonstrated that there was efficacy in achieving abstinence among individuals who were vaping nicotine specifically, not smoking cigarettes, who wanted to reduce or quit their vaping. So I think there's more promising data like this to demonstrate, while this is not FDA approved for those under 18, that potentially these can be strategies utilized in more challenging or complex cases. So moving on in terms of other treatment options pharmacologically, we talked about nicotine replacement therapy. There are also great and evidence-based medications we use to treat opioid use disorder. While again, not as common in this age group, it is something that we certainly see and will treat. These medications act on your mu opioid receptor, much like many other opioids do. Methadone, which is a full agonist, buprenorphine, which is a partial agonist, and then naltrexone, which is an antagonist to the mu opioid receptor. Again, this is a complicated table. We're not meant to go through all of this, but I think the biggest thing here to note is that both methadone and buprenorphine can be utilized in those under 18. And I would say from office-based perspective in terms of prescribing, buprenorphine is something I think that is heavily underutilized and is FDA approved from a sublingual formulation for those 16 and older. There is evidence in the adolescent population to demonstrate for all these medications that they allow for better retention and care, and also lower rates of use of the unregulated opioid supply. These are, again, medications that potentially, for example, if a adolescent is admitted to our hospital in withdrawal, seen by a toxicology service, is something that certainly can be initiated with their guidance. And again, it's an evidence-based medication, but unfortunately underutilized. This is just one study looking at the annual rate of buprenorphine prescriptions for those that are 19 and under. And we have data that demonstrates that timely receipt of these medications actually improves retention, which indicates to us too how important it is, especially, for example, if they're coming in for hospitalization related to something like this, that starting medication early is important as opposed to having them refer to treatment. And invariably, even with treatment settings like residential facilities, not many of them, this is data from a secret shopper study, that like less than 25% of these facilities actually provide evidence-based medication. So I think when we have the opportunity, we should take it. And again, data demonstrates that not many youth who actually have opioid use disorder actually receive any medication treatment. Moving from medications for opioid use disorder, talking about alcohol, and I will say the typical trend for drinking in the adolescent population tends more to be of the binge pattern. And so oftentimes they may not necessarily meet DSM-5 criteria for what we would consider an alcohol use disorder. And we do have medications. This is essentially what this slide we want to acknowledge. Excuse me. However, there's not a ton of evidence in the adolescent population in terms of use of these medications. And I would say that this would really be a case-by-case basis, but I do want us pediatricians to know that there are options out there, especially for more challenging or complex cases, that we can offer these medications on an off-label basis. And then moving to, I think, an important topic of risk reduction, because we do have evidence-based treatment. Many of these pharmacologic treatments that I talked about, there's great evidence for and are effective treatments. However, there are many other things, like, for example, for cannabis use, et cetera, that we don't necessarily have great evidence-based pharmacologic treatment for. And a lot of it relies on sort of the non-pharmacologic based treatments. And I think this is a lot of where when we were talking earlier about SBIRT model, thinking about any positive change as part of an action plan, I think this is where a lot of this idea of talking about risk reduction can be important. And really, I think we have already alluded to this, but there, fundamentally is an issue with just say no. And I think this applies a lot with how we've approached things like sex education as well, where we can tell people that abstinence is best, but that does not necessarily mean that that is the reality. And that substance use and risk reduction occurs on this continuum. It's a spectrum, and I think is applicable, I think, in many different settings. So speaking of just alcohol and how we don't have a ton of data on medications in this population, I think there are ways that we can realistically talk to our adolescents about risk reduction. I sort of think about it in these two categories of reducing acute toxicity and then reducing sort of injury and safety. So thinking about utilizing drinks that have lower alcohol by volume. I think this is a big thing where people don't necessarily know like what % alcohol is in sort of the drinks that they're having. And that one drink may have multiple sort of what we consider standard US drinks in it. So basically like multiple servings in one can. Trying non-alcoholic drinks, setting drink limits, and then things in terms of reducing injury and safety risks, like planning transportation ahead of time, avoiding drinking with other substances, staying with trusted people, keeping drinks protected, avoiding unfamiliar environments, for example, as well. I think just a lot of safety planning around before they are leaving their house to go to a party, for example, is really important. I think can be a role that we can play as well. Speaking of other sort of substances, again, we talked about how cannabis is one of the more commonly used substances in this population. I feel like the world of cannabinoids can get kind of confusing. And so this is a very simplified breakdown of the components that we think about. So there's THC, CBD, and then synthetic cannabinoids. THC is the psychoactive component of cannabinoids, plant-derived, and it comes in many different isomers. So we, as Dr. Lynch was alluding to earlier, the delta-9 THC form is what is considered legal by the federal definition. However, there are other isomers like delta-8, delta-10, THCA. So you may probably have seen ads for this or have seen this advertised in smoke shops where they say like, we have delta-8 here, or we have or we have THCA here. These are the other isomers that are not regulated. Again, it varies state by state because some states have made some of these forms illegal, but in Pennsylvania, they still do remain available. And you can get these at various locations, including smoke shops. CBD is the non-psychoactive component of and is also derived from the cannabis plant. And then synthetic cannabinoids are what's chemically made. They're also psychoactive, typically more potent. Some examples of this may include things like spice or K2. And one thing we know is that as our drug supply evolves, we have also seen similar trends in the cannabis realm, in that the concentration of THC, which is the red line, has significantly increased over time compared to concentrations of CBD. So what I think people are getting in their cannabis products today is much more psychoactive than components that people may have been utilizing in like the 70s and 80s. This is just an example of what you might see at a smoke shop. And then these are examples of, for example, THC-8 products that are marketed as things like candies or gummies or other snacks that sometimes are consumed without necessarily knowing exactly what those psychoactive products are in. So when I think about like cannabis-based risk reduction, because we don't have a lot of great pharmacotherapy, I think sort of the core principles are like, yes, abstinence is most effective. We'll acknowledge that. Trying to avoid early age initiation, because we know that the earlier that people initiate, the more likely they are to develop a lifetime substance use disorder diagnosis. And then really treating the underlying or co-occurring conditions. I know, as Dr. Schlesinger said earlier, a lot of them have co-occurring mental health. So a lot of times addressing that piece is very important. But thinking about sort of these other strategies is like, for example, if an adolescent is admitted for cannabinoid hyperemesis, for example, may not be at the position or where they feel like they're ready to stop, or their mental health concerns related to their cannabis use, for example, worsening their anxiety, really focusing on talking about THC content and providing a lot of education around that, or really trying to use one-to-one like THC to CBD products, avoiding synthetic cannabinoids, again, because those tend to be a lot more potent, avoiding preferring non-smoking options, avoiding things like deep or risky inhalation practices, avoiding cannabis-impaired driving, and then avoid combining with other substances as well. And some unproven or unclear strategies, you may or may not have heard things about like tolerance or tea breaks. This is essentially where, as you continue to use cannabis products, you develop a tolerance. And so people will take a break so that they can sort of rebuild. Where like when they're using cannabis products, again, they can feel the same effects. And I think studies have demonstrated that oftentimes when people return to using cannabis, that they actually tend to use more. And so not necessarily a strategy, I think, that has been proven as what we might consider like risk reduction or promoting kind of health. And then again, using a lot of these other isomers, again, they're not regulated and sometimes contain a lot of toxic byproducts. And so while they are oftentimes considered, like I've heard people call it like weed light or something like that, like it doesn't necessarily mean that they are potentially less dangerous or have less harm from a health perspective. And then, like Dr. Lynch was saying, while substance use rates in adolescents has been decreasing, unfortunately, we have seen in unprecedented rates of fatalities among adolescents, a lot, again, driven by kind of our toxic supply. And we have some data on overdose deaths in adolescents. Unfortunately, a lot of them occur at home. A lot of them occur with a bystander who is present. In less than a third of these cases, naloxone was used, and many of them, when EMS arrived, were already pulseless, and a subset of them were driven by counterfeit pills, which I imagine that this number has probably increased. So I think this points to the importance of education and anticipatory guidance from a pediatric perspective in talking about overdose reversal agents and naloxone, and really providing that education not only to adolescents, but also to family members, recognizing that many times they occur in home with a bystander who is present. And there are lots of other things that we think about from an overdose prevention perspective as well. I think one common phrase we use is like never use alone, but I do think that sometimes the reality for individuals is that they do use substances in isolation and may not be near someone who is a trusted individual who can check in on them. And so there are virtual spotting services, hotlines, for example. One is called Safe Spot that people can call in and someone stays with them and may activate emergency services if they stop responding. So that is one way in which people can utilize these anonymous services. Always starting, if you're using something that you're not as familiar with, starting at a lower dose, and then you can always, kind of titrate from there. Avoiding, again, mixing substances, and then we'll talk a little bit about drug checking services. So naloxone, which comes as a nasal spray, it also comes as an injectable. And really the goal is to restore breathing, not necessarily consciousness or alertness. It is available over the counter, although sometimes it is cost prohibitive, but it is available by prescription from, providers. It can also be available for free through the county. I know that in Allegheny County, there are various Narcan or naloxone-based vending machines. Next Distro is like a mail-based program that will deliver naloxone to people's homes. And then syringe service programs like Prevention Point Pittsburgh, which exists here in Allegheny County, also distribute naloxone free of cost to individuals who request it. And I think, again, something that can be very powerful is having it available in your office too, to provide to individuals. In the offices that I work at, we have this available just for people to take without really any question. And we find that many people we are constantly having to restock essentially. And then it's very easy to use. Again, when you are talking about naloxone and you are providing it to people, it's very important that they actually know how to use it. So what are the signs of opioid toxicity? And then these are the instructions that they come with, but usually they come in boxes of 2. And so you just open it, you place it in a nostril, and then you depress the plunger. And then generally advise that people are placed in the recovery position, which is on their side, supported with their arm and their leg. Drug checking tools are also another way that we can promote reduction of overdose and overdose fatalities, and is a way that people can better understand perhaps what they're obtaining in the substances that they're purchasing or consuming. And so there are various test strips, drug checking strips that have been made commercially available. There are fentanyl test strips. I think this is really helpful in cases where people are or may be in positions where they use counterfeit pills. So for example, if you're buying a Xanax bar or Adderall or something like that from someone else, or if you're at a party, a rave, for example, and you're using something like MDMA or you can test the substance beforehand to look for any adulterants such as fentanyl. And that can really inform the person beforehand in terms of whether or not they want to use the substance, or if they want to use it in a safer way, which may mean doing a much smaller amount before sort of titrating up the effect. There are also other testing strips like xylazine and medetomidine, particularly for people who utilize the unregulated opioid supply. Again, I think this would probably be less utilized in the adolescent population. They are legal in the state of Pennsylvania. Every state has different laws regarding test strips, but they are legal here. And we actually do have them available in our children's ER and then also on 9A. If you talk to the unit directors, they should know where you can access this to distribute it to adolescents who may benefit from utilizing these drug checking tools. And then as all things, I think from a prevention risk reduction perspective, we commonly think about is testing people who are at risk for things like HIV, hepatitis C, et cetera, offering medication treatment when appropriate. And then as pediatricians, I know we all love vaccines, so I don't think I have to talk about that piece. And one thing I do want to highlight as sort of in talking about, because I think a lot of this information, I think there's a lot of nuances to it as well. And so we in the last couple of years have formulated this multidisciplinary work group, including multiple disciplines, as you can see here, where we met bi-monthly and essentially came up with this inpatient withdrawal management and substance use treatment pathway, which went live as of last year in November 2025. So this is available on the Infonet. It does cover a lot of the information that we discussed today, for example, in terms of like what nicotine patch dose should you start someone on, and you know, if we are initiating someone on something like buprenorphine in the hospital, how do we typically do that with the guidance of toxicology and adolescent medicine? You know, we have the DSM-5 criteria in there and other things. And so I think this is a really helpful resource that people can refer to with a lot of this information. And this pathway typically is focused specifically on withdrawal management for individuals who are using opioids, GABAergic agents like alcohol or benzos, and then nicotine, and then focuses on the substance use treatment pieces as well about opioids, alcohol, and nicotine. It's not really meant to talk about like iatrogenic withdrawal nows or other substances, although the harm reduction section may cover some things that might be applicable for those substances. And then we have that guide also includes a lot of our local resources that I have listed here. A couple things I'll highlight: Smart Choices, which is through TIPS, offers free substance use support for adolescents up to 21, as well as families, including like a parental support group. And then Shannon Myers, who is part of Smart Choices, developed this teen substance use guide that's really helpful in talking about the different levels of care for adolescents from a substance use perspective, and can be really helpful for parents and adolescents to look through to understand like what are the treatment options from the non-pharmacologic perspective. And again, just provide additional guidance. There's a toxicology bridge clinic, which again, Dr. Lynch founded, and this offers low barrier virtual only buprenorphine bridge scripts. So if someone is in need of something more immediately, they can access these services. And then from a more like longitudinal perspective, we have various clinics: Kaya, which is our adolescent clinic; IMREP, which is the primary care addiction clinic that I work at, and then CPCDS, which is the dual diagnosis clinic in Oakland, which provides also adolescent substance use treatment and has outpatient and intensive outpatient programs embedded. And again, so just some local resources. And I think, again, you can reach out to any of us. I think we'd be happy to kind of direct you in the right direction, or you can call TIPS, et cetera, in terms of guiding you in what you should consider. So really the big take home points, I think, are, you know, overall rates of substance use are decreasing among adolescents, but overdose death rates unfortunately remain high. SBIRT is an evidence-based framework that is already embedded in primary care practices for approaching substance use in adolescents. And then pharmacotherapy, especially, you know, particularly nicotine replacement therapy and medications for opioid use disorder, are evidence-based treatment strategies that are underutilized, and particularly so in this population. And risk reduction strategies can engage adolescents in care, meet them where they are without necessarily requiring abstinence. With that, I do want to plug again that we do have a adolescent and young adult addiction medicine fellowship. We accept people of multiple disciplines: adolescent medicine, pediatrics, family medicine, med peds, psychiatry, et cetera. And so if you know someone who may be interested in further training, it is an ACAG-ME accredited fellowship and is 1 year. And at the end of it, you would be eligible to sit for the addiction medicine boards. But I do think that we can continue to develop the addiction medicine workforce, particularly among individuals who are interested in working with the adolescent population. Again, 9 in 10 of adults who have a substance use disorder started in their adolescence. So I think, again, points to really the importance of prevention, but also early intervention. And with that, we will take questions.